Hello everyone, this is Marshall Riddle from MCOL, and I'd like to welcome you to our webinar event today. Our speakers today, Maria Basso Lipani, Coordinator, Preventable Admissions Care Team, Mount Sinai Medical Center. We're now ready to get started with our event.
Thanks, Marshall. Good morning or good afternoon, everybody. This is Maria Basso Lipani speaking, and I just wanted to say at the outset that unfortunately Dr. Jill Kalman had an unforeseen conflict, so I'll be presenting our presentation in its entirety. If you could advance the slide to our driving forces behind PACT slide, that would be great. So I think it's safe to say at this point that everyone on the call is familiar with the readmission imperative. That is the national mandate to prevent hospital readmissions and the adjustment of payments to those institutions that continue to have excessive rates. This presentation will be about predictive modeling as it relates to the reduction of 30-day readmissions to a hospital. Along those lines, Medicare, I think everyone knows, will be the first to withhold payments and will focus on 3 diagnoses, CHF, AMI, and pneumonia initially, with more conditions to be added by 2015, and that Medicaid will follow suit shortly thereafter. In fact, in New York State, there is a 3-year goal to reduce not just 30-day but 14-day readmissions by 20%. So what this means is that it seems as though the challenge of reducing readmissions is here to stay and that there is much to be learned from predictive modeling. Next slide, please. I also think by now everyone is aware that nearly 20% of Medicare fee-for-service patients who are hospitalized are readmitted within 30 days, and that's an alarming number. In addition, many of these readmissions are unplanned and appear to be the result of clinical deterioration that's tied to poor medication compliance, lack of follow-up care, and I would suggest, and we'll speak to in a little bit, a whole host of other psychosocial issues that are anything but obvious. What's more, it appears that a large majority of these readmissions are preventable. Next slide, please. Additionally, patients are being readmitted for similar diagnoses again and again, which is concerning and has led the government to wonder whether the quality of care in America's hospitals is not what it should be. And at the same time, it doesn't appear that an increase in care post-discharge, whether that care is home care or nursing home care rather, or primary care, is entirely protective against a 30-day readmission. And yet we know instinctually that we need to collaborate and partner with those entities to make the improvements necessary. So all of this is just to frame the issue. And now the question is, what do we do about the readmission challenge? And how does predictive modeling play a role? Well, the first thing that we did at Mount Sinai was to do an audit of our readmission data and a concurrent review of the transitional care literature to begin to get some clarity around some key points that ultimately influenced how we would approach the problem and address the readmission rates at our own institution. And the first point of clarity that came through our PACT program, which I'll speak about in a little bit, was that we needed to understand that solving our readmission problem would not be possible unless we understood the factors that lead to readmission. So in other words, there is no silver bullet here. The things that drive readmissions were not created by one decision or by one healthcare crisis alone, so we need a comprehensive approach. And this is really a critical point in our learning and something that I want to underscore. At Mount Sinai, we've moved away from defining the problem of readmissions as being solely about a problem with handoffs or poor communication at various points of transition. In addition, we don't solely think that the issue is about helping the patient to become more compliant. It's, of course, about these things, but also about many others. And through our PACT program, we've learned that a tremendous amount of the problem related to readmissions has to do with the psychosocial issues that patients and families face and that are just not obvious during a hospitalization. And I want to give a couple of examples of those. Through the work that my staff has done in applying the model that we created to the patient population that we have targeted, we've learned things such as, one of the issues is often mold beneath a patient's floorboards in their homes. For example, that would be what exacerbates their COPD, regardless of how compliant they are with their medications, regardless of how often they visit their pulmonologist. In addition, we've also seen through speaking with patients and families that there's widespread undiagnosed and therefore untreated depression that's led to social isolation, so that a patient really doesn't have anybody in their life that they can look to grocery shop for them on the day of discharge. Another thing that we've uncovered is is rampant illiteracy, people unable to read or write. And this plays a huge role because a lot of the materials that we provide to patients and families are in writing. And so they desperately try to hide that they're not able to read the instructions that they're handed or to comprehend the business cards that they slip into their pockets. Yet another thing that we've identified is that family caregiving is a huge part of what prevents a person from making their health a priority. If you have a 50-something-year-old patient who has CHF but is also a caregiver to his or her aging parent, chances are that they're going to be spending a lot of time in a doctor's office, but it may not be for visits associated with their own care. So we've learned these things, and we've also learned that reducing readmissions can't be done within the walls of our hospital. So we need staff that can supplement the discharge plan. We need to be able to get to know the patient and to understand what their environment is like. We need to be able to assess the family dynamics. And we need to be able to assess other things, such as what is the true connection between the patient and his or her provider, primary care provider, and specialist. And that's important because we want to know whether or not the person is going to be likely to call that person. For example, if they have CHF, will they be likely to call their provider, when they initially begin to notice swelling in their legs rather than waiting for the shortness of breath that would come a few days later. So we understand that the big picture factors really matter and that we need to be able to tailor solutions to what we find. And this is ultimately what we believe reduces risk of 30-day readmissions, and not just 30-day readmissions, but beyond. Next slide, please. So predicting and identifying which patients are at greatest risk of readmission is challenging to healthcare systems, and there is a need, we believe, to target high-risk patients for care transition interventions. At the granular level, believing that it's best to target patients at the highest risk means that we've been doing things here a bit differently than perhaps they're done around the country. Specifically, we have not shied away from patients who have cognitive impairment. We have not shied away from patients who don't speak English or who are on dialysis or who are abusing substances. We enroll patients who have mental illness, and we also enroll patients who count the park bench as their permanent address. We've tried our model with each of these patients precisely because we know that without intervention, they are among the most likely to come back. So I just wanted to say that I think each institution that's listening today who's beginning to organize around readmission reduction has similar decisions to make. First and foremost, will you target patients at highest risk for readmission? And if so, how will you define high risk? And once you've answered those questions, how will you identify patients for your intervention in real time? And this is where the predictive modeling piece comes in. Prior to our application of a predictive model, the easiest and most low-tech way that we found to begin identifying patients was to use readmission history as a proxy for risk. So we assumed at the outset, and correctly so, as we'd later learn, that the best predictor of future events is often past events. So the patients who had been readmitted before would likely be again, either to our institution or to another.